it made me more acutely aware. It just kind of brought more to the surface about how sort of very homogeneous it is here. It's a very white community. It's a very white county. And less than 1% of our population is Black or African American. About 2% is Native American, and about 14% Latinx. And experiences like this or surveys like this always make me stop and remember that not only as a white person, I'm in a position of privilege, but I also have accidentally landed in a living environment where there's a lot of privilege just inherent by virtue of the lack of diversity in the population.
That was Lisa Blyth, Regional Director of First Things First, Yavapai County. So to begin this episode, just let's do a small exercise. Just imagine or think about the organizations or institutions that you interact with daily. Like you might work for a school or a university or even a county health department. Then you're asked the question, how comfortable do you think that senior management, aka your boss, at your organization feels talking about discrimination, race, and racism? Or how comfortable do you feel talking about race and racism? Well, these are some of the questions included in the Regional Health Equity Survey created by the Community Engagement Core Team at the Southwest Health Equity Research Collaborative, or known as SHERC. In this episode, a shared vision for health equity. How are public health institutions in Northern Arizona, like education, transportation, or public health departments, engaging in knowledge and conversations related to the root causes of health inequity or injustice in our communities? Thanks for listening. I'm Alexandra Samarron, your podcast host. From the Southwest Health Equity Research Collaborative and the Media Innovation Center at Northern Arizona University, this is Fairness First, a podcast dedicated to exploring issues of health equity in the Southwest with a special focus on health equity in Northern Arizona. Here, we believe that good health starts in our homes, neighborhoods, schools, work, and other places that we find ourselves spending time in our communities. Most importantly, everyone deserves a fair opportunity to be as healthy as possible in their community despite where they live. Okay, so this episode is divided into two parts. This is part 1 of the episode, A Shared Vision for Health Equity. In part 2 of this episode, we'll dive into how the Regional Health Equity Survey was created and some of the interesting findings. But for today, in part 1, we're going to hear from someone who actually took the survey.
Some questions in the survey that were about, do you have conversations about race or ethnicity or equality? Do you actually have active conversations in your work setting? Nope. Not to say that it isn't addressed, but we don't have like active conversations about it. Do you feel like you can talk to the different layers of management? Nope.
Remember that voice? That was Lisa Blyth. From the beginning of this episode, Lisa took the Regional Health Equity Survey, and we had the opportunity to talk with her about that experience. So to help us reflect on the conversation we had with Lisa, I have Dulce Jiménez here with me. She is one of the lead researchers involved in the Regional Health Equity Survey. Hi, Dulce. Welcome.
Hi, Alexandra. Thank you. I'm very excited to be here.
Yes, we're excited to have you as a co-host, Dulce. So please, before we get into the conversation we had with Lisa, for any of our listeners who have no idea what the goal of the Regional Health Equity Survey is and why Shirk ended up deciding to do something like this. What would you say to that?
Sure. So the overall goal of the Regional Health Equity Survey is to get an idea of how organizations across different sectors work on local health equity issues and to strengthen their capacity to actually do this work together. When I say sectors, that includes nonprofit, business, private, government, and community groups and organizations. So some examples of sectors are health and human services, community and economic development, education, housing, transportation, policy, and food systems. The Regional Health Equity Survey asked leaders from organizations across sectors in northern Arizona questions to explore how these different sectors can and already do work together to address health inequity in their communities. So, to help us understand the Regional Health Equity Survey and the findings, Alexandra, I know you had a very good conversation with one of the participants, so one of the people who actually took our survey.
Yes. It was, it was just wonderful to talk to Lisa Blyth and listen to how she reflected about concepts like racism and equity in her community. And so why don't we just go ahead and go to that interview?
Yes, let's do it.
So when I think of my work in the context of working at a state agency, it's pretty culturally diverse, and I'm proud of that for our organization. And I think, without sounding like I'm speaking for other people, I feel that most people who work in our organization feel supported and valued and respected. And I also believe that we are good. We're non-racist. Is that the new? I've learned new language: non-racist and anti-racist in the recent events that have occurred in our country, and feel good and proud about that. But one of the things taking the survey made me stop and go, I didn't know the language then, but now I can apply the language retroactively. We're not particularly anti-racist. There were some questions in the survey that were about, do you have conversations about race or ethnicity or equality? Do you actually have active conversations in your work setting? Nope. But then given recent events, it's really upped my discomfort with what I perceive to be us not being very anti-racist. And I'd really like us to step up as an organization to not just be non-racist, but really actively be anti-racist. And as a white person, feeling an incredible sense of responsibility to somehow move that work and not knowing how to do it.
Wow, it sounds like the survey helped spark deep reflections for Lisa in regards to racial equity in our society right now.
Yeah, throughout the interview, I could really tell that she has been thinking about racial justice. The Regional Health Equity Survey asked Lisa things like some questions about race, racism. And in our conversation, she started reflecting on anti-racism and what it means to be anti-racist, both on a personal level and organizational level. And so before we kind of hear more about Lisa's reflection, we want to take a step back to understand what anti-racism is. And to do this, we turn to the work of Ibram X. Kendi, one of America's foremost historians and leading anti-racist voices right now, and the founding director of the Center for Anti-Racist Research at Boston University. So, in his book, How to Be an Anti-Racist, he describes the opposite of racist isn't not racist, it is anti-racist. What's the difference? One endorses either the idea of hierarchy as a racist or racial equality as an anti-racist. One either believes problems are rooted in groups of people as a racist or locates the roots of problems in power and policies as an anti-racist. One either allows racial inequities to persevere as a racist or confronts racial inequities as an anti-racist. There is no in-between safe space of not racist. The claim of not racist neutrality is mask for racism.
Thanks, Alexandra, for sharing that. What a powerful quote. There's a lot to unpack there, right? So anti-racism is all about an active resistance to racism, and racism is not just about individual people and their actions. Instead, racism is a system of oppression that was created by and is kept through policies, practices, and procedures that create inequities between racial groups. So we have a role to play in anti-racism not only as individuals, but also as agencies, organizations, entities, which is what Lisa was getting at earlier, right?
Yes. Ex Candy also describes that the only way to undo racism is to consistently identify and describe it and then dismantle it. And, I think that the process of identifying, describing, and dismantling racism within the institutions we work for or interact with in our social lives can be intimidating, overwhelming, uncomfortable, scary to confront. Feelings that can lead to inaction and apathy.
Yeah, so it's like if you don't have to talk about it, you don't have to deal with these issues that seem too big for any one person to solve on their own.
Exactly. So let's bring it back to my conversation with Lisa to talk about this a little more. Lisa reflected on some of the things she's doing in an effort to be anti-racist. And so on a personal level, Lisa talked about finding small ways to be informed and active. She basically said,
my learning to become anti-racist has, for me, been in little things. So, for example, it has been deliberately choosing books to read with my son that have the characters are people of color. We've been doing that for about a month now. And it's been if I can't read the whole books, I look for a podcast, or I make sure that every couple of weeks, I'm attending some sort of webinar or something like that has to do with the current state of affairs and so I'm constantly trying to find ways to stay mindful so that I don't fall into complacency again. And it still feels like a heavy lift. And which makes me that much more sensitive to what it's like to be a person who lives in skin that is not white all of the time.
I can tell that there was a lot of reflection going on during this conversation about anti-racism, and it sounds like Lisa's being proactive about her learning.
Yes, and as I was listening to Lisa reflect about her experiences, I started to also do some reflecting on my own. So on the personal level, Lisa has some reflections about what she was doing to be actively anti-racist, but there's another level that Lisa talked about, and that is the work level. Earlier, we heard Lisa say she'd really like her workplace to step up as an organization to move beyond being non-racist to being anti-racist. As Lisa explores what it means to be anti-racist on a personal level, she also comes up with solutions to health inequity on the work level. And so one of which is communicating and working across different sectors.
Alexandra, that aligns perfectly with our survey.
It does. So basically, during this conversation, Lisa talked about how one of the things she tries to do is be aware of what's happening in the region and keep all that knowledge fresh in her mind so she can help create connections between people and efforts that could work together. Let's listen to Lisa share an example of how that happened recently.
By virtue of working to be aware of the different things that are happening in our region, transportation has been a really big deal for a very long time. We don't have public transportation. We don't have sort of not to speak of. There are pockets, and there are definitely some efforts. There's some transportation companies that really work very hard, but in terms of public transportation by definition, no. Anyway, because of through the CARES Act, there's funding for transportation departments, and part of the funding I learned, I was in a meeting about community impact about housing circumstances. And of course, transportation came up, and they were sharing. Someone shared that this funding through the CARES Act, some of it for transportation departments, can be used to transport food to people. And I also know from my work, from my day job, sort of, so to speak, that all of the schools are working on their lunch programs. They turned them virtual, and they made the food accessible to kids of any age who may not have even been enrolled in school. But then they were running out of resources, and there were some difficulties. In our more remote rural regions, it was difficult to do it on a daily basis. They were having to do just a couple days a week sort of thing, and compile them and that sort of thing. So I just suggested to the person connected to the Transportation CARES Act funding and the person connected to the work for the school, or working with the schools, a lot of schools, I said, hey, did you know this money exists and you guys could work? And so I just got an email today that their two entities, and then NACOG, a couple of our transportation, Cottonwood area transportation, and then the transportation, I'm forgetting the name of the transportation company in Prescott, and I may be forgetting a couple others, I apologize, but there's about 6 or 8 of them who've gotten together, and they've created a collaboration, these other entities, to draw down this funding so they can get more food out into the communities in Yavapai. And like, that's a really big thing. All I did was tell 2 people to talk to each other, and it's exciting, and it's cool to know that sometimes that's all it takes. And because I sometimes get overwhelmed, like, this is such a big problem, how am I going to do anything? And so it was really a nice experience to go, oh, I just told you 2 to talk to each other. Really glad this worked out, and really glad that more people are going to have access to food in the region.
What a great example of working across sectors to move the needle forward.
Yes, and that's essentially what a regional health equity survey is all about, that multi-sectoral approach. Lisa gave us an example of how local agencies and organizations and local communities can work together to meet the needs of their community and advance health equity.
Right. The other component I was thinking about when she connected sectors in her community was the idea of equitable distribution of funding. I could tell that she understood there was a gap in food accessibility in her community, and that funding the transportation infrastructure could really make a difference. And so I think she identified the funding gap and acted upon it. So we heard from Lisa about the importance of working with other sectors to help our communities be as healthy as possible. She also emphasized that research plays a valuable role in achieving health equity. And so let's hear some of her thoughts about research.
Is research valuable, or right now? Sure, because this is just one phase of our very long lives and experiences. And that information, like, there's a whole kinds of new information, and there's all kinds of things to learn about who we are and how we operate in circumstances like this. There's not going to be another opportunity, hopefully, for decades, in which a circumstance like this presents itself, really sheds light on how we behave. It's useful information, and also life is we're going to always have to continue to support and help people. We have a lot of work to do. And so anything that you're discovering now, or that you're continuing to work on now, it's happening during a crisis time, but it's information that will be used far beyond the crisis to continue to help and move progress forward.
I love it. Lisa's totally validating us in all our work right now.
Yes, I feel so positive and cheered on. Now I feel like I have to do a lot of reflecting of my own, and there's so much work we have to do.
Yes, there is a lot of work for us to do when it comes to health equity. But remember, we are not alone. On that note, we want to share one of Lisa's final reflections. So Lisa said,
I just was thinking, to end sort of on a sentimental, when all this and just sort of all this reflection and everything gets me, and I know when I talk to friends and colleagues too, they're like, oh, and I have this posted on my wall, one of the things that came through from Rumi that says, yesterday I was clever, so I wanted to change the world. Today I'm wise, so I'm changing myself. And so when I get really overwhelmed and worked up, it's like, oh, right, what's the thing I can do today? What's a small act I can do today? And that's sort of the governing principle to keep moving through. So.
Lisa reminded us that there is deep work we have to do within ourselves to recognize and act on our personal and organizational role in advancing health equity. Even when it feels like a problem is too big for one person or organization to solve, we can find hope in remembering that there are many people working towards the same health equity issues. And we can all find ways to work individually as well as together to foster the well-being of our communities.
Join us next time for part 2 of this episode, A Shared Vision for Health Equity, to listen to a conversation with lead researchers Dulce Jiménez and Mark Remiker from SHRC, who are behind the Regional Health Equity Survey design and implementation, to tell us more about what they've learned from participants' responses so far around issues of health equity, the root causes of inequity, and the social determinants of health. We want to hear from you. Visit us on Facebook at NAU Share, Instagram at NAU.share. Follow us on Twitter at Share Arizona, that is CHER Arizona, or send us an email at sherc@nau.edu. Tell us what you like, what can we do better, or tell us what topics you want to listen to in our podcast. Southwest Health Equity Research Collaborative, Community Engagement Corps, and the Media Innovation Center at NAU produced this episode. It was edited by Alexandra Samarron and Dulce Jiménez. Music from Film Music I.O., song titled Fearless First by Kevin MacLeod, licensed by creativecommons.org. Special thanks to NIMHD grant number U54MD012388 and Northern Arizona University Southwest Health Equity Research Collaborative for funding this podcast. Thanks to our Fairness First team, Carmelita Sheaf and Dulce Jiménez from the Community Engagement Corps, and Brian Rackham, Director of the NAU Media Innovation Center. Thanks for making these podcasts possible. I'm Alexandra Samarron. Thanks for listening.
A majority of people who took the survey, when they were describing social determinants of health, they were often talking about them in synergy, like together with other social determinants of health, describing very complex systems of disparity. So a lot of times it was, it wasn't just that people couldn't get jobs. It was that people couldn't get jobs and they also didn't have transportation, and also their rent was too expensive.
That was Dulce Jiménez, one of the lead researchers in the Regional Health Equity Survey. The survey wanted to get the perspectives of leaders in diverse sectors like transportation, education, justice, and economic development, just to name a few, around fairness issues related to health. This in hopes to support organizations or sectors to come together and work to address health-related injustices in our communities. This is what we will refer to as a multi-sectoral or cross-sectoral approach to addressing health inequities. Because, remember, health equity is not only a public health or healthcare issue. Welcome to part 2 of episode 3, A Shared Vision for Health Equity, where we're exploring how our public service institutions in Northern Arizona engaged in knowledge, conversations, and action related to the root causes of inequity or injustice in our communities. Remember, this is a 2-part episode. We encourage you to listen to part 1, where we had a conversation with a survey participant and learned about her own reflections on health equity after taking the survey. For part 2 of this episode, we'll understand what the Regional Health Equity Survey is, where the idea came from, and some of the key findings. Medical doctors Uche and Ani Blackstock wrote a piece for the Journal of the American Medical Association called Serving the People, Body and Soul, Centering Black Communities to Achieve Health Justice, urging us to pay attention to the power in community members coming together to design, implement, and lead initiatives that benefit the health of their communities. Most importantly, Uche and Ani Blackstock emphasized that in order to achieve health equity, we must consider solutions beyond traditional healthcare settings and follow the leadership of communities. So, in the spirit of considering solutions beyond traditional healthcare settings, the Regional Health Equity Survey wanted to understand how multiple sectors define and practice health equity and decide how to advance health justice in their own communities. But to help us navigate through the results of the survey, let's go to my conversation with researchers Mark Remiker and Dulce Jiménez, part of the Community Engagement Core at SHRC. Welcome, Mark and Dulce. Thanks for being here. I think I would like us to start talking about the results of the survey. And to do that, I would like to start with you, Dulce. I know you were mostly involved in analyzing participant responses. So tell me some of the most interesting, revealing findings of this survey.
Yeah, I think for me, one of the most, basic sort of things that we found, but that I thought was, positive and interesting is that there is a clear desire for leaders in the Northern Arizona region to engage in collaboration, especially those more multi-sectoral collaboration that we've been talking about. So leaders actually do want to partner with other organizations and agencies in different sectors, as well as with the community to do health equity work together. And also through the survey, we found that in a lot of cases, they are already doing so. So we learned that also organizational cultures across Northern Arizona are already primed for action on the social determinants of health through these multi-sectoral strategies that leaders identified have worked in other parts of the country. And then the other thing that I wanted to mention was just that participants also identified areas where NAU could help in terms of technical assistance. And that was one of the things that we also noticed and we thought that was interesting was that, they, in general, participating leaders that took the survey, they agreed that research plays an important role in addressing health inequities. And we also found that they value data-driven decisions, but they face barriers to using data, such as lack of useful and up-to-date available data, and then also an absence of expertise needed to analyze the data. So I think that's potentially another area our university, Northern Arizona University, could potentially step in.
Now, I would like us to talk about who took this survey. I know that over 200 multi-sectoral community leaders from Northern Arizona participated in this survey, and the counties represented include participants from Apache, Coconino, Mojave, Navajo, and Yavapai, and Coconino making up the majority of the participants. And I know that also participants had the option to identify with more than one sector.
I think the other piece to that, almost half of people who took the survey identified with the health and human services sector. And followed that's 49%, followed by people who identified with education at 26%, and then community and economic development at 20%. So I think it's important to note that, for instance, when they identified priority research areas that NAU could focus on, a lot of them seem to be focused around health issues or mental health issues or education, which kind of, it might just be because a lot of those participants identified as from those sectors as well. So something else to note about the distribution of sector representation.
Thanks for clarifying that, Dulce. Also, I noticed that in the Regional Health Equity Survey report, which is available on the SHRC's website, I see that among survey participants, there was relatively equal distribution across gender, and also the majority of the respondents identified as white, this being 83% of participants, but also the way you sampled or recruited participants for this survey was by outreaching mainly to leaders within institutional sectors. Nevertheless, 83% white is very telling about who are the majority of people in positions of leadership within health and public service organizations, and if they are representative of the experiences, knowledge, and values of the communities they serve. And so, Dulce, could you talk more about the consequences or implications of this observation?
No, I agree because with, that it could pose a problem, especially since we sampled on purpose to try to capture leadership at the leadership level. So I just think it's, important to say that a majority of them are white at the leadership level. At least the people who took our survey, I am not sure if this is representative of how it actually is. Like, I don't know if we just happened to have more people from this race than any other take our survey, or if this is, truly representative of what that sort of leadership workforce is like. But I do think that it presents a problem potentially in the way that maybe they're conceptualizing health equity or these ideas of health equity. And, if they're a little bit removed from the communities that they're serving because they're in that leadership position, but they also don't necessarily reflect or identify with the same communities that they're serving, I think that could pose a problem for sure.
Dulce, is there anything that you were not expecting to find in participants' responses?
One of the questions that we asked them was to describe the root causes of inequities, but a majority of leaders, or the people who actually took the survey, they described social determinants of health during that question, which we know is different from root causes. We know the social determinants of health are, the conditions in which people are born, grow, work, live, and age. Things like schools and parks and housing and conditions and jobs and all of that, which do not necessarily address how or why economic, social, and environmental conditions are inequitably distributed as opposed to root causes. So something I thought was interesting was that a majority of people who took the survey, they were actually answering this question based on social determinants of health and not so much root causes of inequity.
I think even within public health, people continue to confuse the social determinants of health with the root causes of health inequity. And also the term health equity tends to be thrown here and there, but there is no deep meaning or deep understanding of how systems of injustice work in our society and leave legacies of health disparities and inequities. So it sounds to me that participants were able to identify the barriers to people in their communities being as healthy as possible, but they were not able to explain why those barriers existed in the first place.
But even when they were talking about that, when they were describing social determinants of health, they were often talking about them in synergy, like together with other social determinants of health, describing very complex systems of disparity. So a lot of times it was, it wasn't just that people couldn't get jobs. It was that people couldn't get jobs and they also didn't have transportation, and also their rent was too expensive and these types of things. So people, I think it's interesting that maybe it's a person who identifies in one sector, but a lot of times they're able to see how social determinants of health across other sectors impact people's lives. Even though they're not necessarily talking about those root causes, there's still like some, understanding of those social determinants of health and how complex the systems of disparity are.
Mark, do you have anything to add in terms of the results?
There was one other result that I think we can use to build off of what Dulce is talking about here, that a majority of the leaders almost 100% of them reported that their organization has demonstrated a commitment to addressing these root causes of health inequity, which again, if they are not understanding correctly, is maybe troubling. But on top of that, there were about 70% of them said that their organizations had made deliberate efforts to build leadership capacity in the community or had strategies in place to minimize barriers to community participation. And so we're again facing that issue of folks in leadership making decisions and maybe not involving the community as much as they should be. Discussing how the results are interwoven, looking at demographics and responses to community engagement questions and understanding of social determinants of health. These things are all woven together, and I don't think I realized that until we had this conversation in a way that was different than just analyzing quantitative data, looking at percentages and moving on to the next question. I think that this sort of discussion has been really helpful.
Now, Mark, I turn to you to talk about methods, or maybe researchers would call this the recipe steps for this survey project. So I know that to get the 2020 Regional Health Equity Survey started back in 2018, the CEC met with a group of 11 community leaders who became part of the survey's Community Advisory Council. All leaders came from sectors that included childhood development, education, criminal justice, public health, and policy. And this Community Advisory Council was vital in the design of survey questions that would help understand how leaders in Northern Arizona think about the social and institutional factors impacting health and the uneven distribution of opportunities for people to be as healthy as they can be. And so I know to help gather some of the ideas provided by the Community Advisory Council, you carried out a free listing activity. Can you tell us more about that?
Free listing is a technique that's used for gathering data about a specific domain or topic by asking people to list all the items that they can think of that relate to that topic. In this case, it was our Community Advisory Council members, and they were asked to generate thoughts related to 5 aspects of health equity, which included outcomes, innovations, measurement, sustainability, and then partnerships, because we're interested in that cross-sectoral piece. So what that was they generated a bunch of ideas, and then we, as the research team, took those ideas, which were on Post-it notes, and we used those responses to identify themes within each of those 5 categories. And then each of those themes was used to generate a set of what ended up being community-driven questions for the Regional Health Equity Survey. So once those questions were developed through the free listing technique, we took them back to our Community Advisory Council and said, did we get this right? We've distilled everything that we think you said into a set of questions. Did we get it right?
Okay, so in summary, there was a back and forth exchange with the Community Advisory Council to collect their feedback and finalize survey questions. So what did the final version of the survey end up looking like? And when did you finally realize the purpose of this survey?
Oh boy, I mean, it's tough. I think it might even be. It was a long time after that first meeting with the advisory council that I think I realized what it was that we were actually trying to look for. I'm hoping that this is it, that we've done justice to the question, and that's where I think I'm seeing the results come in and hearing what people had to say. I think that was maybe a moment where I think we actually did a pretty good job putting this thing together.
So, what were the different areas or domains you wanted to explore in this survey, Mark?
In the end, what ended up coming up was roughly 5 domains about community involvement, culture, personal experiences, different partnerships, multi-sectoral partnerships, and then some inspiring research and initiatives.
I can see that these are broad domains. I also know that within each of those domains, you ask questions related to what kinds of training activities were participants engaged through their organizations and what kind of experiences they had with staff and supervisors on issues of race and personal understandings of the social determinants of health. And so at the community level, you were interested in knowing what the root causes of inequity were across sectors and what kind of strategies they have in place to overcome these root causes that are outside of the health sector. So then, Mark, what are these sectors that you're talking about, and what is the purpose of having multiple sectors working together?
Overall, the sectors, when I say sectors, I am talking about community health and economic development, health and human services, law, justice, public safety, parks and recreation. It's a long list, but there are a lot of people involved in aspects of people's lives that can have impact, and we want them all to be able to work with one another. And in order to best understand who it was we needed to engage, we brought our community back in again and asked them, our goal here is to look at these sectors. You all are the experts, and you all know who works in these sectors and who the leaders are. So if you could nominate folks that you think would best represent leadership in these sectors, that's the approach that we took, rather than us identifying who we thought the leaders were in each of these sectors.
I can see that this has been a long journey, and it was a revealing experience to talk about how diverse community sectors in health and public service view and practice health equity. Thank you both so much for your work and this conversation. Okay, so I think a takeaway from this episode can be that there is not one correct way to think about what a vision of health equity is and the right steps to get there. Remember, each community is different. However, a multi-sectoral approach can be a strategy to advancing health equity. One first step in understanding the root causes of inequity is to move away from being stuck in only thinking about health disparities. How healthy a person is or not has a deeper reason than an individual responsibility to stay healthy. This deeper reason is connected to bigger structures of injustice within the social and environmental spaces we navigate every single day. In an issue published by the Journal of the American Medical Association, it is reported that historically marginalized communities have been disproportionately harmed during this COVID-19 pandemic, and such harm is connected to systems of injustice. For instance, Black, Latinx, and Indigenous people in the U.S. are more likely to live in crowded homes, have jobs that cannot be done remotely, need to use public transportation to get to work, have limited access to healthcare, and have historically experienced higher prevalence of chronic disease like hypertension, diabetes, and obesity. And so in combination, all these social and environmental factors have been connected with higher risk of COVID-19 infections, complications, and death. And so one conclusion here is that we need to think about how community organizations and institutions belonging to different sectors collaborate to address overwhelming systems of health injustice. In other words, a multi-sectoral approach requires diverse sectors such as education, transportation, justice, housing, or employment, working together and listening not only to the needs of community, but also to community's knowledge and assets, and most importantly, include directly impacted communities by injustice in thinking about solutions to eliminating health inequities. We want to hear from you. Visit us on Facebook at NAU Share, Instagram at NAU.share. Follow us on Twitter at Share Arizona, that is CHER Arizona, or send us an email at sherc@nau.edu. Tell us what you like, what can we do better, or tell us what topics you want to listen to in our podcast. The Southwest Health Equity Research Collaborative, Community Engagement Core, and the Media Innovation Center at NAU produced this episode. It was edited by Alexandra Samarron Longorio, music from filmmusic.io, song titled Fearless First by Kevin MacLeod, licensed by creativecommons.org. Special thanks to NIMHD grant number U54MD012388 and Northern Arizona University Southwest Health Equity Research Collaborative for funding this podcast. Thanks to our Fairness First team, Carmelita Schiff, Dulce Jiménez, Lisa Dam from the Community Engagement Core, and Brian Rackham, Director of the NAU Media Innovation Center. Thanks for making this podcast possible. I'm Alexandra Samarron. Thanks for listening.